All right, so let's talk about diagnoses now. All right? The clinical record must include all diagnostic impressions, and it must be consistent with the patient's chief complaint, objective clinical exam findings. Again, what was the initial complaint? Low back and leg pain, right elbow. Okay? We did the exams, any diagnostic tests. Now we got to do the diagnoses on these. Because what are we concerned about? Well, we're all really good at putting the CPT code down there, aren't we? Okay? It's getting all the things you need to do before you get to the CPT code that I want you to be focused on. And again, it must clearly support the treatment outline in the treatment plan. All services DME provided in the clinical record must be supported by an appropriate diagnosis which is documented in the healthcare record, and any changes in diagnoses must be documented in the clinical record. How many of you are changing your diagnoses throughout the course of care from time to time? Okay, a number of you. Good, good. You should be doing that. That's part of that progress examination. Again, if I've got a sciatica diagnosis that's a primary diagnosis to begin with, but when I do my progress exam and it's 80% resolved or it's completely resolved, it should be in the not be in the number one position. In fact, you may remove it, depending on the clinical presentation of the patient. In all services, DME provided in the clinical record must be supported by the diagnoses and documented. Any changes in diagnoses must be documented. In many services we see in adults are not supported by diagnosis and or the diagnosis is not consistent with exam findings. So another great example of this, more spinally related, patient comes in, the diagnosis is low back pain, and you're doing a 98941, which is a 3 to 4 region adjustment, and there's no diagnoses for the thoracic or cervical spine. Now, we all understand why low back pain could be a full spine condition, right? Right? Okay. So, but you've got to have the information to demonstrate that and support the need to do a full spine adjustment. Okay? What is the purpose? Well, the patient comes in with low back pain, but they have a very extensive scoliotic spine. Okay? Well, they may require some full spine adjusting, but there should be a scoliosis diagnosis, intersegmental diagnoses. All of those things should be in your notes to support that. So again, the payers, believe it or not, the payers, they just want you to put the information. They don't mind paying you for your CPT codes as long as you can support it, okay? It's not limited to a number of visits. It's limited to your notes. How much information you put in your notes and can you support the treatment that you're doing, okay? So if a diagnosis is in the record, it must be supported by documented clinical exam findings and, again, consistent with the chief complaint, okay? Any questions on that? Got it? Good. Well, let's keep moving on. Let's talk about the treatment plan. Now, everybody sit up a little straighter. This is an area that I really want you to dial into, okay? I'm excited about this because this is probably the weakest area. Okay. Okay. Area. Actually, in Yadkinville, they'd call it area, but in Winston-Salem, they'd say area. In your notes that need to be improved. So let's kind of look at this in a little bit more detail. So for each episode of care, a properly prepared and properly documented treatment plan for the improvement of the patient's condition must be included in the patient's health care record. Okay, so this is a real pain, isn't it? When you have a new patient, this is easy, right? We go through this, we set up the note, everything's fine, we go down to our treatment plan. It's beautiful. It's absolutely beautiful. The problem is the patient that's an active or established patient that has a flare-up in their condition, isn't it? So then they come in and that old low back problem flares back up. You take them off of cash, right, because they've been a maintenance patient, right? So now you're going to put them back on insurance because they have a flare-up in their condition. You got to do all this stuff over again. Make sure you're doing this. I realize it may be 4 or 5 visits for this particular flare-up, or maybe it's only 3, but you've got to go through this whole process again. And again, it's pretty easy when you set it up set that, the whole process up in your EHR, in your note system, whatever it may be. But make sure you redo all this for all those flare-ups. Anytime you're reactivating or having a new condition or a new episode, you've got to go through this process, okay? So the patient's treatment plan must include, at minimum, these 5 things, okay? Fire alarms, flags on this. Treatment goals to improve a functional loss experienced by the patient, or could be included under assessment notes. More about treatment goals coming up. So treatment goals. Anticipated number of and frequency of visits should not exceed 12 visits, as at that time you will evaluate treatment effectiveness, patient progress towards treatment goals, and medical necessity of additional care. Okay, number 2 is important. So I have a tendency to do my first progress exam about 10 visits. That's one of the things I learned by going through my CPR at the end of the month that I would get, is my care plans were going a little bit longer, and so I started doing my progress exams earlier in my care, because then I started changing the rest of my treatment plan based on that progress exam. Okay? So that's what I was doing. So that progress exam is important. So whether it's 8 visits or 12 visits, it needs to be done on the medically necessary number of visits. So for some of you, that may be at 5 or 6 visits, depending on how well the patient is responding to your treatment. Does that make sense? Okay. Number 3, CMT recommended including specific areas to be manipulated with reference to frequency and duration. And all planned therapies, modalities recommended, the rationale for each, including areas of application, frequency, duration, and if time-based therapy is planned, the length of time the service will be provided. And number 5, all other treatment recommended by the provider, including work disability, DME, and any home instructions. So those 5 things. So maybe one of the things you need to do is you need to copy this slide, you have it in your notes, and you put this in your documentation area, and when you're going through with those new patients, have I hit all 5 of these standards in my notes? If I am, great, move on to the next patient. Okay? So all subsequent visits should reference the patient's progress as it relates to treatment goals. And changes or alterations to the course of treatment that differ from the initial treatment plan must be clearly documented and must include rationales. So here's another example of that as well. So you see that patient, that low back pain patient, they come in one day, and you're 4 or 5 visits into your care plan, and the patient walks in and says, oh, so you work on the migraines, right? That's what they say, the migraines. Because why? They were reading some brochures out in your reception area, your hot seat area, and they forgot to tell you that they suffer with migraines. So all of a sudden, you're 4 or 5, and they're going to mess up your treatment plan, right? Okay? Because they're adding a new chief complaint into what you're doing. I say that facetiously. So you're going to stop. You're going to do what? You're going to make sure you document that. You're going to do your physical exam, right? Maybe a new outcome assessment form, that headache disability index, maybe. And then what else are you going to do? You're going to update your diagnoses. You're going to maybe do different therapies. You're going to do all these things. Guess what else? You get to add some CPT codes down here too. So there's more work, more pay. You got to do the work to do the pay. So make sure you're going through that process, reestablishing those diagnoses, updating the treatment goals, all of that, and then you'll take off from there. Does that make sense? Okay. And if there is a change to the working diagnosis or diagnoses, the provider must modify the treatment plan, treatment goals, and or prepare new treatment plan with new treatment goals. Okay? So, again, it could be you have the initial complaint of a low back and right leg pain, and then as you get further into this, they're unresponsive to treatment. I know that doesn't happen in anybody else's office, but they're unresponsive to treatment. You send them over for an MRI, you realize you got a herniated disc, and so you want to update the diagnoses for that, right? And number 1. And number 2, you're going to change your treatment possibly. Maybe you'll continue to do different things in your office, I'm not saying you have to refer the patient out. Maybe you do refer the patient. Maybe you add other things. Maybe you co-manage the patient. So let's say you send them over to the pain clinic to get some help, maybe get an epidural, some localized injections, something like that. Then put all that stuff, those referrals, all that stuff should be updated in your note. So again, I should be able to come in there, pick the note up on that particular day, look at, okay, these are the diagnoses, this is what's going on, and rather than just seeing a CPT code at the end for an adjustment, ICE, muscle stem, and intersegmental traction. There's no change in the course of care. So add that value to the note, add that information to the note. Okay? All covered services included in the treatment plan must be consistent with the chief complaint, clinical findings, and diagnosis. Are you starting to see what my point here? Make sure that that thread throughout your care is consistent, that everything tacks back together. All right. So let's talk about establishing goals and outcome assessments. Don't hesitate to give me a call. This is a quiet crowd. Okay? So if something comes up or I'm going too fast through something, feel free to stop me and I'll be happy to answer those questions. All right, best practices and treatment goals. The goal of the treatment must be to improve functional loss experienced by the patient. And treatment goals must be reasonable, objective, and measurable. Okay? A treatment goal is, I want them out of pain. That's not a measurable treatment goal, other than the fact they're hopefully out of pain at the end of the care. You need to have more specific things. Need to be more functional things. So it could be, I need to get them back to work. Maybe to begin with, you want to get them back to work with modified activity. All right? That would be a treatment goal, is to get them back to work under modified activity by the first progress exam. Obviously, by the end, you want them back to work full duty without any restrictions. So let's say they don't work. Maybe they like to go and they like to do Zumba class, right? So we want to be able to get them back to Zumba class by mid-care or the end of care. It could be the ability to do to vacuum. It could be lifting a child. There are a lot of things that could be involved. Dr. Ayers.
If somebody comes in and says, oops, thank you. What if pain is their chief complaint? In other words, they say, you know, I'm taking a bar class, I can do it, but I've got this chronic lower back pain that's been nagging me for 3 years. You know, I can complete the class, I just wish I didn't have the pain while I was doing it.
Right, so one of the pain is included in that, but it's a functional goal. So in that situation, you would say, if she's going, if she's going to bar class 3 times a week with pain on every time she does it, then you could say our objective is to be able to get her, reduce her pain levels by 50% and continue on with bar class 3 times a week, or whatever that might be.
Thank you.
Mm-hmm. Okay.
Dr. Sharp?
Yes.
Let me speak to that too just a minute. Dr. Ayers, in the Blue Cross, excuse me, in the Blue Cross Blue Shield corporate medical policy for chiropractic, it states that chiropractic services are only covered by Blue Cross if the treatment is to improve a functional loss experienced by the patient. So that's one of the reasons we included this in here, is we didn't just make this up. It's where I'm going. It wasn't just an HNS issue. Generally, I think our Board of Examiners indicates to reduce pain or improve a functional loss. That's what I believe the practice guides say. But Blue Cross's position is there is no chiropractic coverage unless the care is intended to improve a functional loss. So just thought I'd throw that in there.
So you can reference the pain in your goal, yeah, but it has to be tied to a functional activity.
And like you said, we know I'm not a chiropractor, but I think you can. As I understand it from just my conversations with you and Steve, I think it's not too difficult to link the pain to functional improvement, right? Would you agree?
Yeah, it also, there's other things, being able to sleep through the night, being able to, not waking with pain, You know, there are folks that can't go 2 hours without waking with pain and restriction. They have to get up and move around. Those, you know, you just kind of get creative with it. But it really, these goals really paint the picture of what's going on with the patient. So whether it's you know, an exercise goal or a work-related goal or a house goal, whatever it may be, their ability to walk, whatever it may be, those are all real important things. You just need to paint that picture in your notes. Okay? Good question. Yeah?
Oswestry score? You know, the outcome assessment score?
That's going to be one of your goals, absolutely.
Okay.
But you need to have other things other than your outcome assessment forms in there to in your treatment goals. So you need to have more functional goals. But that's part of your goals is to have those measured through your outcome assessment forms. And we'll talk more about that in detail. Okay? Good. Yeah, in the back. On the tree, okay?
Do they need to be done every 4 weeks or 12 visits or just around a 12 visit?
Well, I would do them anytime you're doing a reassessment of the patient, a progress exam. So again, it could be 5 visits because that's when you're doing your first progress exam. Most of us are probably doing progress or re-exams every 10 to 12 visits, particularly for the first one. Maybe not so much that long on the second one, but yeah, that's when I would do that. Okay? Good. Good, good, good. Anything else? Great. Again, they must be improve a functional deficit related to the patient's present condition and should address specific ADLs the patient is unable to perform. There is an ADL outcome assessment form that's very helpful. I like the functional, it's not the functional ability index for my Medicare patients that really talks about that, and then also I do a pain disability index for my Medicare patients. But that the functional ability test really covers a gamut of a lot of day-to-day functional things that would be more related to your Medicare patients. You know, kneeling, walking, things like that that are really important. So you can make it easy on yourself. And also, quite frankly, I've taken some of those outcome assessment forms and kind of pulled things out of those and put those in my EHRs for all of my patients. I'm all about maximizing other people's hard work, right? So you just kind of take that information, you kind of put it in your own words and put it into your notes so you're doing that. So those are very good things. And it should, again, the ADLs are very important. So reasonable, this is an important thing too, reasonable. So we don't take a patient that's had low back pain for the last 30 years and our goal, our stated goal, is to have 100% loss of pain, right? That's an unreasonable goal. We want to look, again, focusing in on the functional aspects of that. So if that patient isn't able to go out and walk for more than 15 minutes without pain, what would be a good functional goal? Well, we want to get this patient, maybe by the end of the care, up to 30 minutes of walking with 25% or 50% improvement in their levels of pain, or maybe just being able to walk for 30 minutes, okay? There are a lot of things that you can do that, but that's a reasonable goal in that particular situation. So you must consider chronic conditions as well as certain structural conditions. What's the patient's pre-injury status? Let's say that we have a patient with low back pain, limited range of motion, and severe spondylosis. For this patient, what would be that reasonable goal? Okay? You want to be honest about that. So again, different between a 22-year-old linebacker on NC State's football team versus somebody that's 75 that can walk 10 to 15 minutes. They're going to have completely opposite goals, all right? So you've got to have reasonable, realistic goals for them. Okay? Objective and measurable. So fact-based, observable goals. Measurable, the goals must be measurable so that we can determine the outcome, the patient's progress, effectiveness of care, appropriateness of continued care, and when MMI has been reached. So let's say you're 16 visits into your care plan, docs, and one of those payers asked to look at your records, right? Those mean payers, right? They want to look at your records. You know they want to discontinue your care because they don't like chiropractors. Well, that's not the case anymore. So what they want to do is they want to look at your notes to see if your care that you're providing for that patient at the level of care that you're providing for that patient is warranted. So if you're sitting there and you've got your outcome assessments, you've got your measurable goals, you're still seeing progress with that patient, whether it's 16 visits or 10 visits or 20 visits, is not that important. But as long as we're seeing progress and we can measure and demonstrate that progress, then you have nothing to worry about, right? So at the end of the day, if Dr. Bender is reviewing your records for that particular patient and has that information, then we're good to go, right? Because then he can say, yes, you know, this care was set here. We've got all of the chief complaints, the exam findings, all the diagnostics were properly, the diagnoses were proper, the treatment plan, and he or she is following through with that treatment plan, measuring, has objective, reasonable, measurable goals, and we're seeing that progress. So boom, 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 you continue to go. Once they get to the point of MMI, then that's a different story. You release them and put them on maintenance care. So again, this is what releases you from the oppression, right? It's just putting this information in there, and once that information in there, there's nothing stopping you as you're treating your patient. Does that make sense? Okay. And outcome assessments are necessary to establish measurable goals. It is, again, the best way to show progress or lack of progress with your patient. Okay? The use of valid and reliable outcome assessment tools in the management of neuromusculoskeletal disorders is considered a best practice. Okay? So you have to do it. So if you're not doing it, you have to do it. You've got to start this. In order to make an objective, valid, and reliable determination and meaningful progress towards treatment goals, and when the MMI has been reached, it is essential that the relevant standardized outcome assessments, OA tools, are utilized during the initial and all subsequent examinations. So outcome assessments help improve treatment outcomes, and they support clinical decision making. So, you know, I'm probably like you. Maybe I'm the only one in the room, but I really want to help every single patient that comes through my office, and quite frankly, I think I can help every patient, but there's sometimes I can't help every patient. So when you're really looking at that, when you sit there and you look at those outcome assessment tools, and there's no change after that first and definitely that second test, it's time to take care of the patient, and that may be referring that patient over out for another specialist or doing something different with that patient. Again, a lot of times what we'll do is at that progress exam, I want to see a minimum of 60 to 80% improvement in the patient's levels of symptoms at least. And if I'm not meeting that threshold, we're going to spend a little extra time changing what we're doing, not continuing or just treating them more frequently. We're actually changing the treatment so we make a better clinical outcome, get better practice for the patient. So, okay? All right, and the initial exam key documentation standard. H&S requires the use of outcome assessment tools as part of the initial examination. Outcome assessment tools should be utilized on the initial exam to establish a baseline. And the outcome assessment during the initial examination are essential for establishing treatment goals which are measurable. So again, I said earlier, everything in your note begins on that first day. Take the extra time with those new patients. I know you're busy. I know there are patients stacking up, okay, in the treatment room or the waiting room or the hot seat area. So go back and finish up later when you've got the time to finish the note. If you're doing an exceptional initial exam notes, it takes a lot of pressure off of everything else. So from there to the next progress exam, you're making small alterations to those assessments, to the related to the initial note. And then when you get to the progress exam, you do another very comprehensive, thorough note, and then you go through the end and at your final re-exam. Now, it's not always just that clean, but make sure you're doing those exceptional notes at the initial exam, progress, and re-exams. Very, very important. And again, outcome assessments, measurable goals are critical. So if you start out good and you've got some good goals, then you can justify your ongoing treatment. So again, re-exams, HNS requires the use of outcome assessment tools on all subsequent examinations. Again, you're billing those 99 codes, that's to do this information, to do these reassessments, so it's very important. So outcome assessment should be used to objectively measure towards treatment goals, should demonstrate effectiveness of treatment, and should determine the appropriateness and medical necessity of continued care, and to help to determine if MMI has been reached, okay? So what is the standard in your office for MMI? When they run out of benefits? When you've hit 15 visits? When they decide they don't want to come in anymore? It should be very objective with respect to that, okay? All right. Without the use of outcome assessment tools during the initial examination and at all subsequent examinations, how do you objectively measure the patient's progress towards their treatment goals? Okay? If you're not measuring and comparing patient progress towards treatment goals, you're just simply not going to be able to objectively demonstrate treatment effectiveness either. And if you aren't measuring patient progress towards treatment goals, you will not be able to objectively determine when MMI has been reached. Okay? Good. So these are some standard forms. These forms are on the website. Staff, this is another set of forms you can download onto your desktop. Docs, if you're not using these forms, they're provided for free for you. This is what you need to do, though. There's one thing, having the forms and having the patients fill them out. The second thing is to use the information. So you need to learn how to score the reports. And I'm going to show you some outcome assessments in the way they're scored in my EHR so you kind of get an idea of the value of those reports. But make sure you're scoring those reports. And doctors, your staff and your patients, well, let's put it this way. These forms, these outcome assessment forms, will only be as important as they are to you, to your staff, and to your patients. So if you're having a hard time getting your patients to fill out outcome assessment forms, it's because they're not important to you and your staff. So make sure your staff understands the importance of getting those forms done and make sure they're getting scored. Now, you may score them, you may have your staff score them, but that information needs to get into your notes as well, right? It's great to do them. Don't just check it off. I've done my outcome assessments. That sharp guy told me I had to do them, but you're not actually using the information, so make sure you're doing that as well. But make sure your patients are doing that. In my office, we try to do them at the first visit. I do my initial exam, and then I determine which outcome assessment forms that I want to use. All right? So we can do it one of two ways. I can actually email a link to my patients so they can do those on their own time via email. What's it take? 30 seconds, maybe a couple minutes to do an outcome assessment form. So they can do them by email, or we can print them off if they'd prefer to do them right there. They come in the second visit. If they haven't done them for the second visit, then they don't get back to see me until they finish that outcome assessment form. So guess what? My patients do their outcome assessment forms. Dr. Bender.
I would just like to add a point that sometimes comes up in review of records is the comparison of these outcome assessment forms need to be congruent with your objective findings that you find in the exam and your observation of the patient along in the treatment program. Sometimes the patients think they're doing themselves good by not scoring these outcome assessment forms honestly. Maybe they think they'll get more insurance benefits if they show no progress. The same thing with like a pain VAS scale. So you have to watch in your comparison of the patient and the previous outcome assessment forms, is this all congruent? Because sometimes it's not, and you have to have a heart-to-heart conversation with the patient to say, you know, you show that you're doing much, much better than these studies that you just completed. why are you doing that? And then they kind of confess to you that they were trying to help themselves.
Right.
So again, sometimes you'll pick that up if you're really paying close attention to that patient outcome assessment.
And sometimes your patients will, particularly with the staff, make sure your staff understands the purpose of these forms. So sometimes they'll kind of say, hey, well, they'll infer that they're going to kind of fix the game. So my staff, or if I see that happen, we'll kind of use a script that just says, hey, listen, if you don't fill these forms out honestly, they're going to deny your benefits. They're going to deny coverage. Well, in essence, that's exactly what they're going to do. They're going to deny coverage because I'm going to have to release the patient because there's no progress. So, just have some talking points. The main thing, docs, you need to understand them, but more importantly, your staff needs to do that because it's probably going to be your staff that's handing those outcome assessments to the patient. It seems like we used to have this, Dr. Bender, a lot more frequently in our practice. I think it's become such an integrated part of our practice, we don't see that very much anymore. And I think your current patients that you're seeing start referring in similar patients into your practice. And so everybody's expectation seems to be congruent with the spirit of the practice as well. So not to say some people don't take advantage of it, but that's very important. But that's a good observation. Okay? All right, good. So these forms are there. You can also get these available in Spanish. I did not have my forms, all of my forms in Spanish, so this is a very good thing. I've got some of them. But again, you can use any tools that you want to. The one little disclaimer I say about outcome assessments, these are all public domain. Some outcome assessments are not public domain, so you need to, they're copyrighted. So if you're using those and you don't pay for permission to use those, it invalidates your notes, and you don't want to be there when there are plenty of forms that you can use. So some of you, I know my forms are integrated in with my EHR, but they're based on Kim Christensen's work. He has a software that you can buy. There are other different forms that you can get. So just make sure you're either using the H&S forms or any forms that you're using, you have permission to use those. Okay? Good. All right, a few more minutes, then I want to take a break. Speaking of outcome assessments, let's kind of look at this. All right, this is a functional ability score for a patient of mine, and I do like this. So it kind of goes through and explains the purpose, the kind of measuring points that are based in this functional ability. So sleeping, sitting, standing, walking, all of that stuff. So there's some explanation in there. So again, you might want to just have this explanation of those forms in your notes attached to it. So whether it's in paper or electronic, I just think it's good to have that explanation in there, okay? Patient results, the outcome assessment summary lists the current functional ability score compared to the best possible score of 100, and follow-up functional ability to score more than the initial score, and optimally at 100, okay? And it's got current treatment results, overall treatment results, and then we come in here and you can kind of see how it all lays it out. I'm going to just kind of put this out here. So you can see every dot here is based on a different date that I did the outcome assessment form for this patient. And you can see things differently. And then up at the top, you can see the numbers. This is an interesting patient. Again, we want to see the numbers going up in this case, right? So that's a good thing. So pain-free function wasn't a big deal. Sleeping, standing, walking, kneeling has kind of been up and down, squatting and bending, climbing stairs. But you can see a series of progress with this patient based on certain dates. The interesting thing with this patient, let's see, 1, 2, 3, the fourth time I did outcome assessments, this is actually a work comp patient, so I was doing my outcome assessments a little bit more frequently on this patient. On the fourth visit, what I did with this patient is I MMI'd them at that point. I felt like I had released, the patient was to be released. They were doing about as good as they could do. She went back to work, and she went back to the orthopedist, and she complained to the orthopedist, and so the orthopedist sent her back despite the fact that I had released her from care, okay? And they asked me to continue on with some treatment. So I said, well, okay, let's try this for a short term. And we went on a weekly adjustment, and you can see what happened. As soon as I put her back under care, she immediately started to become more symptomatic. Now, the question is it similar to what Dr. Bender was referring to? Was she trying to put a fix on the game? I think in this case, she didn't need the treatment. So as soon as we took a look at these, then we released her from care. They tried to send her back in for care. Usually it's the other way, right? They tried to send her back in care, and we couldn't objectively, under these objective results, we couldn't continue to treat her based on our outcome assessments. So the interesting thing is I was fighting the work comp carrier to not treat the patient based on my outcome assessment forms, okay? So that's kind of a unique thing. Usually it's the other thing around, but I thought this is a unique case I wanted to show you. The good part is you can see the progress and lack of progress with this patient, and that it just spells it out just very, very nice. So had they taken my initial MMI report on May 19th, then she probably would have had a better outcome and done better, okay? The interesting thing is now she's a maintenance patient with me, and we're seeing her about every 3 weeks, and she's doing just fine. So, it was a good course of care, but an interesting lesson with respect to this point, okay? All right, and the pain disability score, this is kind of the same. I won't pull this form up. You can see how this works. But again, the key component with this is you should have some explanation of the outcome assessment in your note, okay? And it may just be much briefer than what I have, but in your initial exam note, your progress exam note, there should reference the results of this outcome assessment, okay? Does that make sense? This is a nice report, too. All right, let me finish up with this. In order to make an objective, valid, and reliable determination of meaningful progress towards treatment goals, treatment effectiveness, and when MMI has been reached, standardized outcome assessment tools must be utilized during the initial and all subsequent exams. Anytime you see anything in red today in this presentation, make sure you're doing that, okay? Because if you're not doing that, and those records end up being reviewed, whether it's by H&S or Blue Cross Blue Shield, the claims will be denied. You'll have to write a check back to the carrier, let alone other potential sanctions for that. So I don't know about you, but this is a pretty simple thing to add to my note. It really adds a lot of value to my note, helps me make the decisions. I don't have to intellectually or from my heart make the decisions, because it's all based on fact from those outcome assessments. So that's very helpful.
Dr. Sharp?
Yes.
Let me just add something. Recently, one of our payers sent us some notes to look at, and this doctor had done a really good job having his patients complete the outcome assessments, actually the forms that H&S has on our website. And so this is, what I'm going to say sounds a little redundant, but I think it needs to be said. The payer, it wasn't Blue Cross, had refused additional care. The patient had appealed it. The doctor was trying to just explain why he needed to continue the care, and he even mentioned that, as could be seen in the records, he had used outcome assessments. Every one of the outcome assessments done at each subsequent re-exam showed a regression. So my point is, it's not enough to do them. You have to look at them and compare them to the one done before. You're looking for objective, measurable progress. And I feel like I'm being just repeating myself, but there was nothing that we could do to help support the doctor's attempt to get that care approved. So, anyway, I just wanted to share that with you. And also, we have a little misspelling on there, and we have a little misspelling on that screen. I did sign off on this after I checked it, so we can't blame Dr. Sharp. I just apparently can't spell compliance.
No,
There we go.
I'm changing, this is my word.
Okay. Yeah, it was his fault.
Complainants, it's a higher level thinking word here that we'll have to, we'll need to change that. You know how many times we've looked at this, and every time, you know, until it's blazing up on a screen, do you see that you have complainants instead of compliance? So we're going to backspace that one so you don't have to look at that. But, you know, the great thing, the flip side of this, had you gotten the records, had Dr. Binder reviewed the records, and you had good outcome assessment forms, and probably if you didn't have all the other things that you need to have, but you at least showed those outcome assessment forms, you'd have gone to bat for them, right? Absolutely. Yeah, yeah. So I think that's important. We want you to do everything right, but those outcome assessments are just such an easy tool to use to add more value to your notes. So, okay? Any question on outcome assessment forms before we take a break?
One more thing, too, to speak to that. If just because the patient had regressed, if the physician had then done a simple revision to the treatment plan with, you know, modified his goals and changed the care,
That's a good point.
then we could have supported that. But he continued to do exam, stem, and traction week after week, month after month. Exactly the same care. So,
Yeah, that's a very good point. A very good point. You know, so often, quite frankly, aren't we used to patients getting well? You know, don't most of your patients get well? It's very unique in chiropractic. Most of our patients come into our office and get well. So when one doesn't get well, sometimes it's hard to not even believe that they're not going to get well, just if I treat them a little bit longer. Well, this helps put up a little reminder when you have to stop and do these reassessments and look at it. So maybe you need to adjust the low back in a little different fashion. Maybe you need to use a drop table. Maybe you need to do some flexion distraction. Maybe you need to stop doing those things. Maybe you need to go side posture. Quite frankly, maybe you need to refer them down the street to another chiropractor that does a particular, maybe does something else that you don't have that capacity in your office. So I'm all about making sure that you're utilizing the other professionals, whether they're medical professionals, other chiropractors in the area, as long as it's there for the benefit of the patient. That's very helpful. Okay? So on that note, I think let's take a few minutes. We'll take about 15 minutes. We've got some great donuts and coffee back there, and we'll get started with complainants shortly.